Good afternoon and welcome to everyone who is online with us right now. We'd like to welcome you to the webinar titled Assessing Growth in Children and Adolescents for the Screening, Treatment, and Prevention of Eating Disorders, presented by Ms. Anna Lutz. A few things to note: participants will be muted upon entry and videos will be turned off. If you need any technical assistance, we ask that you use the chat box function. At the last 10 minutes of the webinar will be designated to address any questions for the presenter, and we would like for you to place your questions in the Q&A section in order to ensure that we can address those questions. In approximately 3 months, you will receive an email requesting feedback on the impact of today's webinar. And lastly, we would encourage you to visit the NSEED Training Center at www.ncedis.org/training to view other webinars and training opportunities. At this time, I would like to introduce today's presenter, Ms. Anna Lutz, who specializes in eating disorders and pediatric and family nutrition. She is a certified eating disorders registered dietitian and an approved supervisor, both through the International Association of Eating Disorder Professionals. Anna has previously worked at Children's National Medical Center in Washington, D.C., where she served as an outpatient registered dietitian at the Delaney Eating Disorders Clinic. She is also a national speaker and delivers workshops and presentations on eating disorders, weight-inclusive healthcare, and childhood feeding. Anna also serves on the board at the Carolina Resource Center for Eating Disorders. She currently writes about nutrition and family feeding, free of diet culture, at Sunny Side Up Nutrition, and has worked in private practice since 2006. I will now turn things over to Ms. Anna Lutz.
Great, thank you, Courtney, so much. I'm thrilled to be here today and to be talking about a topic that's important and near to dear to my heart. So today we're going to be talking about growth in children and adolescents. And Courtney did a great job introducing me. I have a private practice in Raleigh, North Carolina, where I see individuals with eating disorders and supervise other dietitians. And these topics that we're going to be talking about today come up over and over again. And so I'm thrilled to be talking to other professionals about these topics. So our objectives, there's 3 sections that I'm going to go through today. One is screening. So the importance of assessing growth charts when we're screening individuals, specifically children and adolescents, for eating disorders. Then the second part is going to be talking about treatment or establishing an expected body weight, how to use growth charts to establish if someone has an eating disorder, how we think about and discuss weight. And then thirdly, we're going to talk about prevention in your practice, thinking about how to approach all clients from a weight inclusive perspective in the hopes of preventing eating disorders. So what we know is that eating disorder rates are on the rise. You can see here that this study that came out in 2019 showed a doubling of worldwide eating disorder rates. Which of course is quite concerning. And now during the COVID-19 pandemic, we are seeing more and more information about rates increasing. I know personally, just the need for our services gone up so much. And so we're in a situation where I'll need to be on the lookout and know that if we're seeing clients or patients, most likely we're seeing someone with an eating disorder. Specifically with adolescents, you can see the prevalence rates. You can see that binge eating disorder has the largest prevalence. When they expanded the criteria from the diagnostic criteria for anorexia nervosa and bulimia nervosa and expanded that to behaviors that suggest, you can see how the numbers increase, and that the mean age onset of eating disorders is 12 and a half. And something that I think is really important to note is that eating disorders affect everyone, all races, ages, socioeconomic background, all genders, all body types and sizes, and all sexual orientations. It affects everyone. What we also know is that there are many barriers to care. Not everyone has equal access to eating disorder treatment. And so, one way I see that we can be working on that is for us all to be educated about eating disorders and for us to work on that, our own bias about who has an eating disorder and know that it affects everyone. A lot of what I'm going to be talking to today is backed up in this brand new paper from the American Academy of Pediatrics that came out just this past January, less than 2 months ago. So I wanted to point people to this paper if you haven't seen it already, particularly the pediatricians that are here. This is a great paper that lays out the identification management of eating disorder in children and adolescents. And another important thing to note is that eating disorders are defined by behaviors. They're not defined by weight. And so, we're going to be talking about growth and weight a lot today, but really remember that eating disorders are behaviors and that none of us can look at someone and know if they have an eating disorder or not. We can't weigh someone and know if they have an eating disorder or not. Weight and weight trends can be clues, but they are not the diagnostic criteria. So we're going to talk a bit about screening. So when thinking about the primary care provider's role in eating disorder screening, they're well positioned because on an annual basis, they're weighing and measuring the children and adolescents that come and see at their annual visit. And so they can follow these trends over time. That's a really important piece, but it's also really important to ask about eating and body image concerns. Has there been a change in eating, a change in exercise? What else is going on in their life? Major life stressors? Has there been mood changes? What else is going on? And then after this kind of full assessment, deciding if a referral is needed or not. So these are blank growth charts pulled from the CDC website. The boys is on the left, 2 to 20-year-old growth chart, and the 2 to 20-year-old girls growth chart is on the right. The blue lines represent when the time on average when the rate of height increase is at its highest. So the growth spurt for each of these growth charts. So when the child is growing the quickest. And what we know, this correlates with puberty. And what we know is when a child's height is increasing greatly, their weight is also increasing greatly. The red line on the girls' growth chart is the average time of menarche, which is about 12.6 years. And so there's a lot of changes that have to happen before a girl has their first period. The reason I'm pointing this out is that we know that this age group, there's so many changes happening. On average, children are gaining at least 10 pounds a year on average to stay on their growth curve. And this can be alarming to parents. It can be alarming to the child who may not understand puberty. If taken out of context in the healthcare system we all work in, it can be alarming if someone says, "Oh my goodness, I've gained 15 pounds this year." If we see it through, a more weight focused perspective, and we have our own weight bias, that might be alarming. So really thinking about that children's bodies are supposed to change, and they change dramatically as they're supposed to. Just to kind of talk more about this, and this is specifically for the female body composition changes during puberty, that fat mass increases again so that periods can start. And it's significant. You can see that the change in body fat is 120% during puberty for girls. And in 4 years, on average, a girl will gain 40 pounds. And so again, it's just interesting and important to kind of highlight these changes that are happening and need to be happening. And it's very healthy to happen as a child goes through puberty. And this data is from in Haynes, and on this time on the right we have boys and on the left we have girls, and it's a change in body fat percentage, and over time. And it's interesting to me, and this is something honestly that I learned, is that you can see the girls' curves of going from age 5 to age 19, um, body fat percentage increased more smoothly, I would say, quite a bit more slowly than the boys. The boys had a more drastic increase that then fell and then started to increase again. Again, just interesting information about how bodies change. So we're going to talk a bit about more about growth curves, and we're in we're talking about screening. So this is an example of a child that is high tracking weight for age. There, you can see that their stature for age chart is on the left. This person is quite tall compared to their peers. They're tracking above the 95th percentile, height for age. On the right, we see someone who is tracking above the 95th percentile, weight for age, on the right. This child is tracking, even if their height percentile was lower, let's say their height percentile was closer to 50th percentile or lower, and the weight percentile look like this, that would be fine too. This child is growing very predictably. Genetics plays a big role in our body size and shape. I want to point out, I know this is really different than how many doctors and dietitians are trained traditionally. But what we know is, when we talk to children who are tracking predictably, there's not a concern with their behaviors in general. They're tracking and growing as their body intended. So opposite of that this is an example of a child that's low tracking weight for age. Okay, and so I didn't specifically go into this at the last slide, but the bottom of the growth chart is age. So we've got 2 going over to age 20. This particular growth chart combines weight and height. So the bottom one is weight. Going up the y-axis, we have weight. And then they have also put the height chart on there. So starting above the weight, you can see different heights. And so each time the child goes to the pediatrician, they're weighed and they're measured, and a point is put on here. So you can see here, this child is growing between the 25th and 50th percentile height for age. And for weight, they're growing on the lower end. They're smaller, they weigh less compared to their peers, kind of hanging on to that bottom between the 10th and the 5th percentile. So this is what we would call negative dysregulation. This gets into the things that are a bit more concerning. Those first 2 examples, I wouldn't be concerned about either one of those children by just looking at their height and weight, not asking them any questions, just looking at their height and weight. This is concerning. You can see at age 12, between 12 and 13, this is the height, this is the weight curve. This child was tracking right along the 75th percentile, and then there was a drastic drop. This would need great attention. What is going on? Why has this child lost weight? They've crossed percentile lines. And then kind of looking over at the height curve, you can kind of see there hasn't been a big change. This last little bit, they're starting to fall off their height curve, probably from malnutrition, to make some assumption. But this is something that we would be concerned about. What's going on? There are lots of possible causes to negative dysregulation, and it can be as drastic as that example, or it could just be a slowing of weight gain that where the child is not staying on their own growth curve, their own specific growth curve, and so they might still be gaining weight, but they're growing. They're gaining weight slower. It could be an indication of eating disorder. It could also be, appetite suppressing medication. We see that quite a bit. There could be something going on with other things that interfere with a child's intake that's not an eating disorder, sensory processing disorder, as an example. Maybe there's something going on endocrine-wise. Of course, we want to rule that out. Something that we're going to be looking at today is the possibility, and that would not be from the example I just showed, but late onset puberty also will make a child look like they're falling off their growth curve. If If they're developing later, they're hitting their growth spurt later, everything's going to be shifted over in the growth curve. And so, they might still be gaining weight and gaining height, but it's not at the rate that the average population is. And again, that's what's tough, is the growth charts are about averages. Huge population data is used for these growth charts, but we're really only now, when you have a client or a patient in front of you, you're only thinking about what's going on with this patient. So we need to figure out what might be going on. Has there been a significant change in activity level? Is there anything else going on autoimmune wise, GI wise? And so really kind of assessing that. So the opposite of that negative dysregulation would be acceleration in weight for age. So this is an example here where the child was growing along the 95th percentile and started to veer off of the curve that they had kind of established for a while. Their height jumped up a little bit, the percentile between that second point, which is a little bit after age 3, and that third point, which is a little after 4, jumped up a bit, and then kind of, it's finding its curve. It didn't change a whole lot. And so I look at that. Was there a big change in their weight? Height? Did their height go way off their growth curve? Does that explain where there might have been a change in their percentile of their weight for age? So what might cause that? It could be natural growth that doesn't follow population averages. And I think we need to remember that the growth charts are helpful, but not every children follows the exact pattern that these averages have mapped out. There could be something going on emotionally, psychologically, that could be affecting their intake. I wonder, was there a history of restrictive feeding in the past? And as the child grows older, they have more autonomy with their eating, and that restrictive feeding might have led to more the child making sure they're going to get enough food. Is there early onset puberty? So the opposite example of what we were just talking about. If a child goes through puberty early, then things are going to be shifted the other way. And so oftentimes we'll see the height go off the growth curve early, and the weight, and there might be early puberty that kind of veers back to their original growth pattern as the years go on. Is there a restrictive eating disorder that's leading to a restrict and binge cycle? What might be going on endocrine wise? Has there been new medication? Has there been a change in activity level, either increase or decrease? What else is going on? But what we do know is, regardless of the cause, that if we try to control someone's weight, what we know from the research is that leads to weight acceleration and weight cycling, meaning, encouraging dieting, losing weight and gaining weight. And there's so many health consequences associated with that weight cycling. So again, we're talking about the screening. So when we're using growth charts, we want to make sure we're looking at this patient's growth chart, not comparing them to others. And that's an important piece that I often explain to parents, is that we're not comparing your child to others. Let's look at how they've been growing since they were 2, what's been going on, and has their weight for age crossed percentile lines. If they're plotting along, whatever percentile it is, 95th percentile, 100th percentile, 5th percentile, they've been plotting along there, that's not something I'm concerned about. But if they have accelerated weight gain, wherever that is, veering off their growth chart curve, let's be curious about it. Or if they have decelerated weight gain, let's be curious about it. And that deceleration could be slowed weight gain, like we talked about. It could be no weight gain. And children are supposed to always be gaining weight. There could be weight loss. And let's be curious and figure out what's going on. Let's check the height, see if the height explains what might be going on with the weight. Let's assess for puberty. Where are they in puberty? Is there early puberty, late puberty? And then ask those important follow-up questions. So I get asked a lot, so what do I do with the BMI growth curve? And you can see that I haven't put up a lot of BMI growth. I don't think I put up any at this point, BMI growth curve. What we know is the way the BMI is, very small changes in height and weight make huge changes on the BMI growth curve. So it's quite volatile. BMI in general is not helpful for individuals. It wasn't designed to treat individuals. And so I personally really think we gather a lot more clinical information by focusing on height for age and weight for age. Now, if a height has drastically crossed percentile lines, up or down, sometimes it's helpful for me when I'm trying to determine expected body weight with someone who needs to weight restore. And we're going to talk about that in the next section. I might look at the BMI chart to help me kind of gauge, because if someone was trotting along on the 50th percentile height for age, and all of a sudden now they're at the 90th percentile height for age, so they've really jumped up. Their weight for age percentile needs to be higher because they're now taller, and so I might be kind of using that as a clue. Um, Also, the way that BMI is, if someone is taller than their peers, they're higher on the height for age growth charts, they're more likely for that BMI to be higher. And so sometimes it's not the most helpful indication. Another thing to note is Z-scores. So the space that's above the growth charts is uncalibrated. So above, some growth charts have the top percentile is the 95th. Others, the top percentile line, excuse me, is the 97th. Opposite is true below. The lowest percentile line is 5th, or the lowest is 3rd. Once you get above or below those percentile lines, the space on the growth charts are not calibrated. So you can't look at percentile changes by just looking at it. You need to be using Z-scores to see if they're moving further from the mean. And I use just a simple Z-score calculator that you can use to kind of assess where they are. So here's a quick example that I wanted to show you. We're going to call this client Jane. And you can see that Jane, between age 7, and that's the earliest information I had, was kind of plodding along on a pretty consistent growth curve, and veered up a bit at age 9, and kind of jumped up to the next percentile line at age 9. And then between 11 and 12 and a half, there was slowing and kind of veered back to that original line. And then there was a lot of weight deceleration. An eating disorder was diagnosed here around 14. There was some weight gain, but not back. Full weight restoration wasn't achieved, and there was some continued weight loss. So this is her height for age. And what you can see is right along between age 10 and age 12 and a half, her height really jumped up in percentile lines. And what's of note is that if you look back at the weight between 10 and 12 and a half, there was that kind of deceleration that would be concerning, because the height was really, increasing, but we saw a little bit of that mimicking of the weight increasing. And I think that's why she jumped up between age 9 and 11 and 11 and a half. But then that deceleration was a clue that something might be going on. And just to look at, I wanted to kind of show you the kind of more drastic changes you see on a BMI chart. So this would be something that this negative deceleration that at 12 and a half, it'd be important to kind of wonder what's going on. And I think it might be an example of someone maybe praising a child for slowed weight gain, kind of, oh, good, you're getting back to that line. But I think it also, really digging in there, asking questions would have been a clue that an eating disorder was starting. So we really want to remember that weight and height are only clues, right? They're defined a lot of times as vital signs. They're only clues. And so we want to use them to help guide our questioning. But then we really want to ask about dieting behaviors, body dissatisfaction, experience of weight stigma. Have they been bullied? Have they been told? I have a lot of clients that, might have gone to a pediatrician's checkup and were told that their percentile was too high, they needed to lose weight, and then they've really been restricting after that visit. And so we want to ask about what's going on. Has there been changing in eating habits? We know from the research that people with eating disorders do report that more than people who don't have eating disorders that they have a history of being a vegetarian. That doesn't mean people that are vegetarian have eating disorders, but if, it's a clue to listen out for if you have a teenager that has decided to be a vegetarian and their family is not. Has there been changes in exercise habits? What else is going on in their life? Doing an assessment for abuse, trauma, and is there amenorrhea? And that paper from the American Pediatric Academy that I showed at the beginning, the extensive, more thorough questions are there that you can pull. So I don't love the name of this, but this is atypical anorexia is the term that is used right now in the medical field to describe someone who meets all the criteria for anorexia nervosa, but accept the criteria that says they need to be significantly underweight. And so, but what we know from research is that people who have atypical anorexia, meaning they're greatly not eating enough, their body image, they have great body image disturbance. All of the medical complications are the same for regardless of what someone's weight is. And so that any weight loss in children really needs to be evaluated with concern, no matter what the premorbid weight was. And another thing that I think is really interesting is this research from Dr. Lowe about weight suppression. So weight suppression is defined by someone's current weight, and this study was done with people with eating disorders presenting for treatment, and they compared it to their highest weight. So, what their current weight was compared to their highest weight. And what we know, what they found in the studies is the bigger that difference is, the more severe the eating disorder behaviors and the less improvement in treatment of their symptomatology, regardless of what their weight was currently. That difference in the highest weight compared to the current weight was a really significant predictor of how they were doing in treatment and how they were doing at presentation. This graphic, I think, is a great graphic to kind of illustrate that. So you can kind of see the cookie, the little gingerbread people on the right, the yellow ones, they're all the same weight, but the bigger the difference between the green and the yellow ones, that's kind of, he's predicting the first one is a low weight suppression, moderate and high, and just how important that is to progress in eating disorder treatment and current symptomatology. So we all want to be listening. I think that's an important kind of take home today is, we'll hear clients or parents say, oh, he's just thinned out. That's what all his siblings did too. If we're looking at a growth curve and someone has fallen off their growth curve, well, that very well might be true, but that probably doesn't mean that the siblings fell off their growth curve. You could look at it and assess it. I've never weighed this much in my life. And I like to say to adolescents, you're right. And that's how it's supposed to be. As an adolescent, you're always growing and gaining, and your weight's going to continue to increase. That's what needs to happen. Or I've gained 10 to 15 pounds over last year. Yes, that's normal. That's what happens during puberty. Let's take a look at a growth curve. If there's concern about periods, people talking about exercise, and we know that, from the research about exercise and periods, how important it is for an athlete to eat enough to sustain their periods, to protect their bones. If you hear things about, I've totally cut out any kind of junk food, I've made all these changes, or kind of focusing on trying to make a change. And these are, when I wrote these were things I was thinking that adolescents and teens would say. All right, so we're going to keep moving into treatment. So the eating disorder treatment team, at a minimum, usually includes a medical provider, a psychotherapist, and a registered dietitian. And today we're focusing a bit more on the PCP's role on the eating disorder team. So they're assessing and monitoring medical stability, along with the registered dietitian. Essential weight is one term that's used, or expected body weight. They might give clearance for exercise, med management, and emphasize health and vitality. So what is a healthy weight? And that's probably something I'm hoping will be something that you leave this webinar thinking about. What is really a healthy weight? We can look at charts and we're taught that there are certain cutoffs, but when I think about what a healthy weight is, I think about someone eating well, listening to their hunger and fullness, moving their body in a way that feels good, and having the energy they need, not thinking about food too much. When we don't eat enough, we think about food a whole lot. But I think we need to start thinking about this term healthy weight in a completely different way. So there's traditionally, and even some continues now, in eating disorder treatment, there's this difference in these terms of ideal body weight, which is strictly looking at an adolescent or child's at their current age, what is the 50th percentile weight for age, or BMI for age, and saying that that's the ideal body weight. And a more nuanced way for treatment is to really look at someone's historical weight, their where they are in puberty, their menstrual history, assessing their intake, really doing a full assessment and coming up with what we would call an expected body weight that's very unique to this patient. And that is really what's shown to help with long-term relapse prevention. So when we're determining an expected body weight, we want to assess the historical growth trajectory, looking at those growth curves. I'm asking myself, has the height crossed percentile lines? If it has, then it would be expected the weight for age would also cross. So we need to take that into account. We need to always be projecting 6 months out. So if I'm figuring out a patient's expected body weight now, I am looking at what they would need to be 6 months out on their growth curve. So if they're 12 now, at 12 and a half, what would they need to be back on their growth curve if weight restoration is needed? I really encourage providers to think of it as a minimum, maybe a range, but a lot of times if there's a range, then we're saying, it can be interpreted you don't want to go up above a certain weight. So a minimum is a nice way to think about it. And, for health and vitality, I think we need to be above this minimum, and that we need to be reassessing in children and adolescents every 3 to 6 months. It's a moving target. By the time we get to that first expected body weight, it's been 6 months. So we need to move it ahead, stay ahead of the ball. So going back to Jane, if you kind of remember, if we're looking back at where she presented, which was age 14 and a half, and then we look at the height curve that also crossed percentile lines and stayed up at that high percentile, then we really want to get her back to that new curve that she started to plot when her height jumped up. And that what we know is that probably is going to really reduce her risk of relapse. It's going to support recovery. That's what I want to talk about a little bit, because we have this evidence that shows that as little as 5 pounds can make all the difference in someone starting to have regular periods again. It can be just that little difference, and that an expected body weight may need to be set. There's some research that shows 2 kilograms above where we might think it is to start the menstrual cycle back again. And so knowing that we don't want to be setting expected body weights too low. This is something I come up against a lot. I'll be really honest with you, with my clients, but also the other adolescents that we see in my practice, is parents and other providers being pretty concerned, wanting expected body weights to be set lower, saying they don't want their child to be, quote, overweight. They felt so uncomfortable before their eating disorder, and they don't want them to feel uncomfortable again. And so, really thinking about the health risks of having a sustained eating disorder for a long time, and not kind of, and this is talked a lot in that paper I've been mentioning throughout, is that really not having parents really kind of use that to influence how we set expected body weight. That fear that I think is really influenced by our culture, diet culture, how we think about bodies. If that starts to dictate how we treat people with eating disorders, we're really stuck in a cycle there where diet culture is playing a role in the development of eating disorders, but also the treatment of eating disorders. We know that full weight restoration supports recovery. As little as 2.2 kilograms has been shown to drastically reduce a person's risk of relapse. And I love the metaphor that Carrie Arnold talks about in her book, Decoding Anorexia. If you're trying to get up a hill, if you're right at the top of the hill, but you're not all the way at the top, it's really easy to slide back down. But once you get over that hump and you're at the top of the hill, you can kind of look around and play around up there. And what we find is that if we stop treatment too early when the client is on this side of the hill, it's so easy for them to slide back down. And so we really need to be looking at full weight restoration. So what if we don't have historical growth curves? This is like, I always get excited, honestly, when I can get my hands on historical growth records. I can really look at a growth curve. I can really assess it, but that's not the case a lot of times. And so we might defer determining expected body weight for later, and just say, well, we're gonna, let's try to get above this minimum, or let's just see how this goes. And let's focus on these other things. And so again, I'm talking a lot about weight today, but there's plenty of people with eating disorders who do not need to weight restore. And I would say actually most of the people who have diagnosed eating disorders, weight restoration is not a piece of their treatment. And so that we need to be focusing on normalizing eating patterns, and looking at their signs of health. And usually these things fall into place when someone is at the body weight that their body wants to be. So true signs of health. These are just some examples. And this is a list I love to make with my clients when we talk about weight, and they might be concerned about where their expected body weight might be, or where their body might end up at the end of treatment. And we might together just make a list of what is true health? How is health really defined? That we're told that it's defined by weight, but truly there's so much more than that. Okay, so we've talked a bit about screening. We've talked a bit about using growth charts in the treatment of eating disorders, and that was mostly for individuals that needed to weight restore. And now we're going to move into prevention. So thinking about in your own practice, how you might practice with all individuals through a weight inclusive lens as to, be a part of the prevention of eating disorders. I think us are trained, including myself, to treat people with eating disorders in one way and treat people without eating disorders in another way. And so I love the way Jessica Setnick, who is a registered dietitian, talks about this. She talks about universal precautions for eating disorders. So just like when we take people's blood, we use universal precautions. We put on gloves, right? We don't wait and figure out if someone has a bloodborne illness before we put on the gloves. So just the same way, we don't want to wait and see if someone has an eating disorder or see if someone's going to develop an eating disorder before we treat them from a weight inclusive lens. If we treat everyone that way, we focus on health behaviors and not weight, then we're preventing eating disorders. So I have here risk factors of eating disorders. This is pulled right from the National Eating Disorder Association's website. And I've highlighted things that I think as medical providers that we could play a role in, or maybe the best way to think about it is that we could not play a role in, that we can not encourage dieting or negative energy balance, that we can work on decreasing weight stigma in our offices, that we can not play a role in body dissatisfaction of our clients. There's a lot on this list that we might not be controllable, we'll say, or if we think about it from an individual's perspective. But there are some things in the treatment of eating disorders or the risk factors that we do play a role in, and we can kind of think about that. All right, so what we know from the research is that long-term dieting doesn't work. We know that dieting behaviors in children and adolescents is associated with increased BMI and binge eating in both girls and boys. So if the reason that someone is dieting is to decrease their weight or their body mass index, long term, we see that doesn't work. And we also see that it increases eating disorder behaviors, binge eating. In this study, 14 to 15-year-olds, dieting behaviors were the strongest predictor of eating disorders at 3-year follow-up. So that's pretty significant. 3-year follow-up, the strongest prediction of eating disorders was dieting behavior. And that weight talk is associated with both increased risk of eating disorders and high BMI. So weight talk being weight talk in the home. The study was specifically weight talk in the home among parents. Focusing on weight, people needing to lose weight, even if it wasn't directed towards the child. There was this increased risk of eating disorders and increased BMI. And what we know about feeding practices is children that have restrictive access to highly palatable food have increased intake of those foods. And so this is a study that people in my field quote a whole lot, which is they took children, and it was actually girls, and they divided them into 2 groups. One that had access to snack food at their homes, and one that did not. And individually, they put them in a room with a bunch of food, a bunch of snack food, and they assessed how much they ate. And this was in the absence of hunger. And the children that did not have those foods at their home, did not have access to those foods, ate quite a bit more of these snack foods or highly palatable foods. We know that maternal restrictive feeding practices predict daughters eating in the absence of hunger. And so that restrictive feeding doesn't help, um, um, eating competence, children listening to their hunger and fullness, and increased BMI. And that parents' attitudes about overweight, how they talk about people's weight is predicted of restrictive feeding practices. And, you'll notice through this talk, I haven't been using terms like overweight or obesity just because I think they are pathologizing terms that evoke weight stigma, but studies use these terms. So I do use those terms when they're used in the studies. And so what we know is that, just the way parents think about weight really predicts how they feed their children, and that restrictive feeding isn't helpful in the long run. So this is another piece, if we're working with kids and adolescents, how we talk to the parents about weight. So weight stigma, I've mentioned weight stigma a couple times, but weight stigma is discrimination against or stereotyping others based on weight. And what we know is that weight stigma comes from all parts of our culture, including healthcare professionals. And that experiencing weight stigma leads to depression, anxiety, poor body image, social isolation, unhealthy eating behaviors, and increased BMI. And so again, even if we think, you know, um, discriminating against someone because of their weight is going to quote help with their weight, the research isn't there that happens. It actually causes quite a bit of harm. So what we know, there's in 2016, the American Academy of Pediatrics came out with a paper, and it's in the resources here. And it was a focus on health. What they said was let's focus on healthy behaviors rather than weight. And this was a paper that was written about that there's so much overlap between children that are diagnosed with quote unquote obesity and children that are diagnosed with eating disorders, and the risks are very similar. And so when we're practicing, let's focus on healthy behaviors and not be talking to children about weight. So to kind of continue on that, is to just remember that weight is a clue. What weight is doing is a clue. If a weight veers way off above that acceleration, yes, we should respond to it. We should really be wondering what's going on. What might be going on in the home, what might be going on eating wise that might have caused that. Let's just be curious. What are the behaviors or experiences that might be going on? I really encourage, I think growth curves and weight is complex and confusing even for adults, and talking about it directly to children can be really confusing and scary. I never want a child to hear that there's something wrong with their body and that something drastic needs to happen. And so if there is a concern, if it's possible, the way your practice is set up, to talk to parents without the child present. And then refer to someone for further assessment and support. But let's really focus on those behaviors. That's another kind of big take home, that weight is not a behavior, but it might be a clue into other things that might be going on. We want to screen for trauma, food insecurity, teasing, bullying, what else might be going on. that this weight change on their growth curve might be telling us something. And there might be nothing going on. And I do want to say that too, there might be nothing going on. So we want to encourage health promoting behaviors. There's so much research about activity, family meals, eating regular meals and snacks, getting adequate sleep, that all these things support health. And if we change our dialogue in our offices to focus on these behaviors, that these support health and don't cause the harm that we know that focusing on dieting and restricting does. Positive body image is not a behavior, but I wanted to just put that on there, that we know that positive body image supports health, feeling good about our body. There's really interesting research that shows the more someone has good feelings about themselves and their body, the more likely they are to engage in these health promoting behaviors. And so as health professionals, we don't want to be the ones that are leading to negative body image and causing that body dissatisfaction. And we want to really be discouraging behaviors that don't promote health, discouraging dieting and skipping meals, discouraging weight talk, discouraging prolonged screen time. And I wanted to highlight that this quote is interesting to me, which says that longitudinal data of adolescent females suggests that even though body weight percentiles track throughout adolescence, little consistency guides the intake of the energy, nutrients, vitamins, and minerals from early to late adolescence. So even though how a child tracks on their growth curve is pretty consistent and predictable, their intake, what they're eating, is not. It's very volatile. And so as health professionals, we want to refrain from jumping to conclusions about the dietary habits of adolescents, even if they have been evaluated in the past, and take time to assess their current intake before jumping to conclusions. All right, so we're getting to the end here. So in conclusion, we really want to think about that weight can be one clue in the development of an eating disorder, but it by no means is the whole story. Someone can have an eating disorder without their weight changing at all. But we want to be on the lookout, especially if we're in the primary care setting and we're assessing growth charts on an annual basis. Let's be curious behind the dysregulation. It could be a sign of disordered eating. It could not. Let's just be curious. We know that full weight restoration and nutritional rehabilitation decreases rates of eating disorder relapse. So we don't want to set the expected body weight too low, so that we want to support full recovery. We want to focus on behaviors, not weight. And so it might be something tangible to think about, is when you might be trained to talk about weight and to do an intervention regarding weight. How can you turn that around to focus on a behavior and really take the weight out of it? Do not talk to children about their bodies being wrong. I think that's a big one. And that really comes from both the research, but it also comes from, I've treated eating disorders for almost 20 years now. And so many stories are about children being told by a healthcare provider or a parent that their body was too big, and that was a big part of their development of an eating disorder. And so, I think as we all want to practice from a do no harm perspective, thinking about how we talk to children and following that American Academy of Pediatric guidelines of not talking to children about weight. And to remember that genetics has a big influence on body size and shape, and that weight gain is very normal and expected throughout childhood and is at a really higher rate in the teen years. And so here are the references. And then I'm happy to answer questions. Thank you so much.
Great, thank you, Anna. We will now begin our question and answer segment. And as a reminder, we do ask that you use the Q&A box so that we make sure we can address your question. And if we have any questions that we did not get to answer because we run out of time, I will make sure to send those to Anna, and she will provide responses, and I will email those out to everyone. As a quick reminder, following today's webinar, you will receive an email with a link to the evaluation form, as well as a copy of the slides from today's presentation. And if you know anyone who would be interested in viewing today's presentation, we will have this available on demand in our training center in about 2 weeks or so. So Anna, the first question is, do you have any recommendations or experiences you can share regarding the assessment and treatment of ARFID and the key differences from other eating disorders? So,
That's such a great question. I think it's important for us all to be trained in treating ARFID because we're seeing that more and more, I think, because it's a fairly new diagnosis. I really love the resources from Katja Rowell. I'm going to spell her last name, Rowell, and her work with responsive feeding. I think that's a great idea for maybe a future webinar, is to really focus in on ARFID. Courtney, remind me what the first part was. It questions about resources or
so
about
if
ARFID?
if you had any recommendations or experiences you
Okay.
could share regarding the assessment and treatment.
So I do work with quite a few people with ARFID, and so do the dietitians in my practice. And what we know is this eating disorder has been present. Of course, it's not a new eating disorder. The diagnosis was new. It was added to the DSM-5 in 2015. And prior to that, the similar diagnosis. So I'm going to first, ARFID stands for avoidant restrictive food intake disorder. So extreme picky eating, for those who don't know that term, ARFID. And the diagnosis was in the feeding disorder part of the DSM-4. And that whole section was eliminated. And this new diagnosis of ARFID was put in the eating disorder section and can be diagnosed in any age. And what we see is that it's a pretty big diagnosis that has a lot of different subtypes, and that there's certainly an overlap with sensory processing disorder and autism spectrum disorder. Other people might develop ARFID because they've had an incident, like a choking incident, and might become very scared of food. There's a big association with trauma and ARFID. And so, we really want to be careful with assessing what's going on. And the way we treat people with ARFID may need to be different than the way we treat people with anorexia nervosa and bulimia nervosa, and to particularly figuring out what was the cause, since there's so many different presentations and subtypes.
Great. And part of that too, Anna, was differentiating between like someone with assessing sensory difficulties, possible autism spectrum disorder or condition,
Yes.
ADHD or learning disability, and involving occupational therapists or other experts in neurodevelopmental conditions.
Yes, I think that's a very important piece. Anytime we're assessing someone with an eating disorder, and to assess for sensory processing, to assess for trauma. And when I'm working with an individual with ARFID, I'm really hoping to find an OT on the team that really understands the nervous system and how feeding and the nervous system kind of overlap.
Great. The next question is, if a child was overweight by 20 kilograms and developed an eating disorder and is now a normal weight for height, do you want them to regain that 20 kilograms or just normal weight gain throughout adolescence?
I think that's a question that I get asked a lot, and I think it would be on, I'd have to ask lots of questions. And so really what we want is for that client to have that health and vitality that we talked about, so that they're eating in a way that's not restrictive, that they're thinking about food less, they're moving their body. For some people to do that, they might have to regain to premorbid weight. Some people don't, and it's, metabolism is complicated. But what we don't want is for someone to maintain a restrictive eating disorder in order to keep an artificially low weight for them. And so that is a lot of work and communication between the dietitian, the family, the adolescent, of really figuring that out together.
Okay. How do you respond to pushbacks from parents when you raise concerns about their children's recent weight loss?
It's a great question. When I can, I really like to show them the growth chart when it's available and to explain. I know I'm a visual learner, and so that really seems to help parents when you can show them the growth curve and explain to them what we're seeing on the growth curve. Um, Also, really talking to them about any kind of weight loss would be concerning in a child. We need to assess what might be going on if there has been weight loss. Um, and really sometimes I'll name, we're in a culture that weight loss is praised. It makes sense that you might have different feelings than I do. But what we know is that specifically in children, we really need to respond to this and do an assessment and figure out what might be going on. But I do really like if I have the growth charts to kind of explain that, if I have the time. In my setting, in an outpatient setting, a lot of times I do have the privilege of having that time of sitting down with parents and kind of reviewing growth charts.
Okay. Anna, I know you provided your references. Are links to the papers that you mentioned available in your references?
I think most of them are there, the links.
Okay. And do you have a reference that you can provide for determining expected body weight?
So I've cited on those slides where expected body weight is discussed in several different papers, including the new paper that came out in January from the American Academy of Pediatrics. There's not a consensus. A lot of the consensus is that we need to use historical growth charts. That's the consensus, that you'll see that wording throughout all the papers is we need to use historical growth charts. There's different approaches, and you can kind of look in the different papers to kind of see those different approaches. But when it comes down to it, what we know is looking at where the child was pre-morbid, before their eating disorder diagnosis, we need to get them back to where they were for their symptoms to fully subside.
Okay, and then also along with that is, in your opinion, how much do you think the RD should or can be involved in determining expected body weight?
Well, I really think we're well positioned to and should be playing a pretty major role in it, because again, we have a lot of times we have the time, we're able to meet with clients for longer. We have we might be a lot of the dietitians meeting with individuals with eating disorders are specialized in eating disorders. So they've had a lot of advanced training and practice determining expected body weight. So ideally it's a team effort, it's a discussion with the pediatrician or the PCP, and that you're looking at it together. But the expertise that the dietitian, especially the eating disorder dietitian, can bring, I think needs to be a pretty significant part of that decision.
Okay. How does early onset of puberty factor into determination of the EBW?
It's a great question. So if I'm gonna go back to those blank growth charts to kind of show you, if you and Courtney, you said early puberty.
Early onset, yep.
Early onset. Okay, hold on one second. Just going to get back to these. Okay. So I'm just going to go over to the girls just to pick one or the other. But we know that this red line, like I said, that's menarche, average age of menarche. But let's say someone had their first period at age 11. What their growth charts might look like is that their height and weight for age really cross percentile lines before the 2 years before 11, that there was this sharp increase because they were having their growth spurt earlier than on average. And then what we often see is that over time, you can see on this blank growth curve, if you just are looking at the height one, the slope of the lines start to come down right around where that blue line starts. You can kind of, the second blue line, the slope starts to come down and it levels off, right? Well, that's going to happen earlier for someone who has early puberty. Their slope of their line might start to curve more around 12, 13 instead of 14, 15. And so same with the weight, you can see this starts to level off where it was really sharp between the two. It starts to level off some. It still goes up, but it levels off some. And so a lot of times what we see is they'll return to their line, their own wait for age line before their early puberty, they'll kind of return to that, and it'll look like they're crossing back. They will be crossing back. So you want to take it into account that they might have shot up, but after puberty, they're going to kind of veer back, if that makes sense.
Okay, and it is 2 o'clock. I just want to be very mindful of everybody's time. I know we did not get to address all questions. I will send these to Anna, and then Anna will get me those responses, and give us about a week, and we will get the rest of these responses out to everyone who
Definitely.
attended. Anna, thank you so much for today, and thank you to all who attended.
Thank you, Courtney, and appreciate everyone for tuning in.
Great. Bye.
Bye.